Hello and welcome to the Canadian Digestive Health Foundation's presentation of therapy options for managing ulcerative colitis. The Canadian Digestive Health Foundation is here to help you. We are the foundation of the Canadian Association of Gastroenterology, and we are supported by physicians and scientists who specialize in digestive health and disease. It is our mission to empower people like you to take control of your digestive health with confidence and optimism. Our objectives this evening are, first of all, to welcome you to this special presentation. We hope to provide each of you with practical, beneficial information that will help you better understand the therapy options that are available for managing ulcerative colitis. Next, we want to introduce you to Dr. Pierre Paré, a highly respected gastroenterologist and researcher from Quebec. The Foundation would like to thank Shire Canada for partnering with us on this educational event. Without their support, this session would not be possible. We hope to provide each of you with valuable information that you can use in your everyday lives and when speaking with your healthcare partners. The session will be recorded and available on our website at www.cdhf.ca so that you can review the information again at a convenient time or share it with your friends, family, and colleagues. Our expert this evening is Dr. Pierre Paré. Dr. Paré is a professor of medicine at the University of Laval in Quebec City. He's a staff gastroenterologist at the University Hospital Centre. Dr. Paré is Director of Clinical Research in Gastroenterology at the University Hospital Centres. His publications include more than 90 peer-reviewed papers, book chapters, and 90 abstracts. He has served on several Canadian Association of Gastroenterology consensus meetings as the co-chair or a member of the steering committee. His current research interests include quality of life and patient-related outcomes in IBD and in functional GI disorders and clinical trials in IBD and gastroenterology. So let's get started. I'll turn it over to our expert. Welcome, Dr. Paré.
Thank you, Catherine, and thank you to the Canadian Digestive Health Foundation to have this opportunity, and mostly each of you attending the session, which hopefully will answer your expectation. Well, my learning objective is first to define for you what is ulcerative colitis, understand the risk and benefit of therapy, which is a highly important issue for your management or the management of patients you may know of, explore the most common therapy options, and learn how to manage your symptom and live positively with ulcerative colitis. Well, ulcerative colitis is one of two inflammatory bowel diseases that you might know. One is a Crohn's disease, and the other one is ulcerative colitis. They both affect the intestine to become inflamed, and they are caused by an abnormal response of immune response. And often for ulcerative colitis, it's diagnosed in late teens and in the early 20s. Unfortunately, it does impact quality of life, ability to work, attend school, engage in social activities, issues that we can measure in questionnaire that we call quality of life. Overall, there are more than 100,000 Canadians living with the disease, with 4,500 new cases diagnosed each year. Canada is one of the highest incidence country with inflammatory bowel disease. It is a chronic condition, which is unfortunate, but it is important to understand, and it requires regular medication to minimize, risk of flares, and hopefully to achieve and maintain a remission. Well, what are the signs and symptoms of ulcerative colitis? Ulcerative colitis mostly will present with diarrhea with blood and mucus. For most of the patient, it often causes frequent false urges to defecate, and that's bother the patient quite commonly. This might be a severe symptom, although it does not reflect the severity of the disease. It just reflects that it is the severity of inflammation might be more located into the rectum. There might be abdominal pain and cramps, and in more severe cases, a patient may have fever, weight loss, and fatigue, and often these patients will require, second-line therapy or be admitted to the hospital for some time. There might be extraintestinal symptoms that may occur, including arthritis, sore eyes, and skin rashes. The ulcerative colitis, in contrast to Crohn's disease, affects only the colon. It's always involved the rectum. Indeed, it goes proximally from rectum to above. It's a mucosal inflammation. It means that the superficial lining of the colon, it's not in the deep layers of the intestine. Deep ulceration of the colon might occur, but only in severe cases. Sometimes it may cause severe bleeding from the bowel, and there is a continuous distribution of inflammation with no escape areas, which all of these aspects are differential issues from Crohn's disease. Well, how does it course, ulcerative colitis? It goes by flares and remissions. Spontaneously will go by flares and remissions. So our role as a physician is to control the flare with the patient and to keep the patient in remission, not to have more flares. A flare is the time when the disease is active and cause symptom, and this is exactly what a patient should avoid. A remission is an absence of disease activity, and previously we wanted to have absence of symptom, but more and more we consider that inflammation within the bowel should be under control. So it's more than symptoms, it's inflammation within the bowel, which can be assessed by endoscopy or other tests that we might discuss later on. So remission is what a patient should wish to achieve and hopefully maintain for long term. What are the options in terms of treatment? And then I'll go over a few things, but perhaps with disappointment for some of you because of lack of knowledge that may meet your expectation. Dietary consideration, over-the-counter or non-prescription medication, prescription medication, and surgery. But overall, treatment option has to be individualized, and hopefully a carefully taking physician will direct you to the appropriate treatment and inform you about exactly what is required for your health. Well, dietary consideration is something that we physicians, and I think probably much more commonly your patient faces. The main objective is to maintain excellent nutrition. Healthy patient has a better course than obviously someone who may not be healthy in terms of nutrition. There are no specific foods shown to be offensive, despite clinical experience, clinical research. We unfortunately never found any special food that may be offensive. One of the aspects is just like patient may consider that they have intolerance to food, which is due to a normal reflex into the body. Just like after you were born, if you're fed 6 times a day, you may have a bowel movement. A child will have 6 bowel movements in the same day. This is not because it goes right through the colon or through the intestine. It's just because this is awakening the normal reflex, which is between what we call the gastrocolic reflex. When you put food into the stomach, it gives a message to the colon to contract and to bring the content close to the rectum and to empty the rectum. But we don't have any, very precise information about food to avoid. So the general recommendation is to respect personal intolerance, because it's hard to say that one type of food, it's not possible to say that one specific food will cause symptom to all of the patient or a majority of those. Over-the-counter medication, it's very popular to consider probiotics. Unfortunately, there are many types or of probiotics available in the market, and all of them may contain different, good bacteria. So a study done with one type of probiotic may not apply to all of the patients. We don't have strong data that probiotics may change or the course of the disease. Obviously, at the time that the patient has a flare, it's much more important to focus on proper therapy with drug that we know at the present time than to rely only on probiotics for which there is no proof of efficacy. Well, often, antidiarrheal drug, could be considered, but it is only advised if by a physician and when a patient is in a stable condition with no severe symptom, in which state it is totally contraindicated. Well, all type of supplement can be considered in terms of feeding, in terms of ensure or other of that sort to maintain good nutrition, and sometimes supplement of iron might be necessary to. It's very important to consider that. Pain it might be an issue in some patients more severe, but we have to be cautious with narcotics because it's for a chronic disease with pain on and off. It's important not to generate a new problem, to be dependent on narcotic about which anyone may get addicted to without knowing exactly. It's very important to be directed on the use of these drugs if pain is present. Well, treatment option can be simple or more aggressive. It depends on the state of the disease. Obviously, some second or third degree medication, what we call stronger medication, might be used to achieve remission. Once remission is achieved, we have good drugs that can maintain remission as far as one is compliant. And obviously, there are benefits and risks to all treatment. So, in general, for, let's say, a mild ulcerative colitis, meaning mild symptoms, it's usually managed by mesalamine or 5-ASAs. These are, the same drugs, either orally or rectally or both. And then, in some cases, more severe patient may need to have corticosteroids for a short term. In those failing or being more dependent on corticosteroids, meaning that they have to take it on more often, immunosuppressive drugs are used. And lastly, for patients who need it, biologics are used at the present time to keep the patient in remission. In fact, no treatment is not an option, but we do understand that some patients may prefer not to have a treatment, just like to ignore they have a disease. But the best way to ignore a disease is to have it under control. So there might be a price to pay, but at the same time, that will increase quality of life than to be facing some flares and sometimes some risky flares in terms of quality of life consequences. So no treatment may mean recurrent flares, negative impact on general health, negative impact on your activities, and perhaps, as that is not true, but increased likelihood of surgery. Well, mesalamine or 5-ASAs, 5-aminosalicylic acid drugs, includes brand names like Asacol, Pentasa, Salofalc, Mesaban. They are used to treat usually mild to moderate ulcerative colitis. They might be still used for more severe, but not as the sole treatment. They will be a basic treatment above which other therapy will be added. But this is not clear if this has to be continued when we use second-line or third-line therapy. They are usually very safe drugs. They do not contain sulfa. Sulfa was contained into a previous drug that was used initially long time ago, sulfaperidine and sulfasalazine. And because of the sulfa component, there were the restriction to use higher dosage. So without sulfa, we can use higher dosage of the 5-aminosalicylic acid drug. These drugs reduce inflammation. They can be administered in capsules, tablets, suppositories, liquid. There are two types of release method to target specific areas of the GI tract. Mostly the site we want to treat is the colon, then early release or modified release or controlled release, and both can achieve the objective that we have as a treatment. They are usually very safe, but occasional possible side effects may include, low appetite, nausea, vomiting, headache. Usually, these type of side effects may just disappear after some time, or sometimes we have to decrease the dosage, and sometimes it does cause cramping into the stomach too. But generally, they are very, very safe drugs. Steroids these days have usually a bad reputation, but I think we should not consider it to be a bad reputation drug if it is required. They are required for treating moderate to severe UC, and they can suppress the immune system, and they act more broadly than the inflammation within the bowel itself. It's more like a controlling of the general immune system of the body. They are powerful drugs and fast-acting. Fast-acting meaning that if one is deserving to have steroids, doesn't mean that one will be under control totally within a couple of days, but within 10 to 15 days, the patient should be very, very improved and hopefully close to what we call in remission. So they are used to achieve short-term remission when the 5-ASAs do not control inflammation, but they are not used to maintain remission mainly because they do not work, and they will have more harm to maintain remission, meaning that obviously some rare patient may need to take it for a longer time than the usual course, which will be anything between 8 to 12 weeks or around, okay? So they are available in tablet, liquid, again, and suppositories, but obviously suppositories will be for a rectal inflammation and not for a systemic or severe disease. And just to remind you that corticosteroids that we use for treating UC are not the anabolic steroids used by athletes to perform better. They are totally unrelated. Obviously, there are possible side effects, but they are generally safe when used short-term. They can cause what we call moon face. For younger individuals, they may trigger acne. They may, unfortunately, cause a new growth of body hair. They may cause weight gain, muscle weakness, occasionally, but very not commonly. In children, we try to avoid them because they may decline the growth rate. They may delay puberty. In some individuals predisposed to diabetes, they may trigger the diabetes. They may cause high blood pressure. Obviously, they have good effect like increased energy. And some patients at high dosage may have depression or mood swings, insomnia, and night sweats. But these are usually very personal side effects, and often they are related to the dosage, which, if it's possible, can be decreased more fastly. So rare side effect, but can be serious, like diabetes, osteoporosis. It's more if a patient will be exposed to take it long term, but we definitively do not want to use long-term steroid therapy. That's why we have alternative. Okay. And pressure in the eye for short-term use is usually not an issue, but for someone who may have to take it a longer term, that will be a consideration to observe. Immunosuppressant, it seems like a bad name, but it's I like to think of that like drugs that just modulate the immune system to slow it down to a proper level to decrease the excess inflammation caused in the body, and causing the inflammation into the bowel. So they were originally developed to prevent organ transplant rejection. So they are known and used for a long, long time. They are very well known. We use it in ulcerative colitis and Crohn's disease for many, many years also, probably on a regular basis for about 15 years. And previously we will use it more uncommonly because it was the early days of using them. Unfortunately, they cannot bring a patient in remission. They can take several months, up to 3 months, to take a full effect. It's a progressive effect. So they are often used in combination with steroids to make sure that we can stop steroids and maintain remission after the steroids are discontinued. Obviously, they are used in oral form. They may lower the white blood cell count, and in some cases they may increase susceptibility to infection. But steroids is probably more an issue in terms of severe infection than immunosuppressive alone. They help maintain remission. And these drugs are what we call cismercaptopurin, Imuran, and methotrexate. They can cause side effects, nausea and vomiting initially, which usually these symptoms are often related to either the timing of taking the drug or to the dosage. So often we try to manage that by increasing the dosage more slowly. Sometimes there are allergic reactions to the drug, about which we cannot do anything else than to stop. Allergy to the drug may present like fever, joint pain, malaise. And then they may have affect blood cell count. So that's why a patient being placed on immunosuppressant, they need to have blood tests regularly, initially, to make sure that it is safe. And when it is under control, to continue to have blood screen, every 3 months to monitor the potential side effect, which are not common, but yet very important to recognize. Rare but serious side effects may include hepatitis, inflammation of the liver, lung inflammation, and severe bone marrow suppression. In many areas of Canada now, we can measure an enzyme which is responsible of the metabolism of that drug and can easily help the physician to predict if this may occur. If this may occur, obviously we will avoid the drug in these individuals. Biologics are the modern drug that were more commonly used up to recently for Crohn's disease, but well-done studies were done, and promising data are there, and they are important drug to consider in ulcerative colitis as well as in Crohn's disease. They are genetically engineered protein originating from human proteins. They turn off overactive portion of the immune system. Indeed, in inflammatory bowel disease, like in the ulcerative colitis, there is an increased production of a protein which is very, very inflammatory, which we call TNF-alpha. And that drug, these type of drug, biologic drug, just blocks these TNF-alpha circulating into the blood or bound to the cells to stimulate inflammation, and consequently they decrease the amount of inflammation and decrease the damage to healthy tissue. They might be given either intravenously, patient have to go in a clinic or a hospital, which is Remicade, or subcutaneously through self-injection and training, and this is about Humira. These drugs may have some reputation of a seriousness, but indeed they are rather serious drug, rather a safe drug. They are infection are more common, but it's usually the the usual infection that one get, perhaps more commonly, like sinus infection, urinary tract infection, chest infection, but usually they are not the serious infection. There are infection caused by standard bacteria. Some patient may have some side effect, which is temporary, like headache, nausea, fatigue. Rash or psoriasis may occur. Psoriasis might be an issue or a rash, but for most of the patient, it can be controlled with topical therapy. So there are some chronic infection that makes a contraindication to use it, like chronic hepatitis B. So we screen for these infections before one is started on the treatment. It can reactivate tuberculosis, so again, we screen for tuberculosis in a proper way to make sure that the safe will be used safely. There might be infusion, rare, reaction with Remicade, or injection to the site of injection with Humira. There are rare side effects like lymphoma, skin cancer, liver injury, rare. Indeed, lymphoma per se is not. It's a lymphoid gland cancer. It's quite uncommon. The risk is with the biologic themselves, with no other drug, is very low. The risk is increased more with immunosuppressive drug than with biologic per se. Well, adherence is a major issue, mainly for ulcerative colitis, because when a patient goes well for some time, there is a temptation to stop therapy. And to remain in remission and have a good quality of life, adherence therapy is very important. So I see adherence to therapy resulting from a balance between the perceived benefit of therapy by the patient and the perceived risk of therapy for the patient. So it's easy to say for myself as a physician, but it's the only way for a patient or to understand properly the objective of adherence is to have open and ongoing discussion with the physician or with the healthcare provider team and try to understand exactly risk, benefit, and determine what is best for you. The risk of surgery? Well, majority of patients will never have a surgery in ulcerative colitis. Okay? The period where the risk is highest is the first 3-4 years. So for myself as a clinician, I always try to convince as much as I can the patient to be highly compliant to therapy, not only to therapy, to medical follow-up, to try to understand the disease. Usual as a patient, try to get, to have your expectation met in terms of education, knowledge. Obviously, that may come from different sources, but often your physician should be the proper source, and you should insist. If a visit is too short, you have to find a way to explain that you need that. And often in some center we have healthcare professional nurses, IBD nurses, that can do quite a good job for that and be part of the team. If surgery occurs, maintaining continuity to the anus is possible for a long time now, when appropriate. It's appropriate for most of the individual. There are side effects also to that, but nevertheless, when surgery is needed, it's because life is more at risk than the colon. So when there is a risk for life of a patient, it's all important to consider surgery and not protect the colon. Surgery obviously cures, in bracket, the disease, but obviously is not without consequences. So again, cannot say that being compliant will be the the guarantee to have a good outcome, but being compliant to medical follow-up, to medical therapy in general, is what the patient can do the best to have a better course than if a patient is not compliant. So what you can do to maximize your health? Well, take your medication as prescribed. If you want to modify dosage or whatever, please don't hesitate to discuss with your physician, your healthcare professional team. Make sure to have regular visit to see your gastroenterologist. Obviously, when you're in flare-ups, you need to have more regular follow-up, and the gastroenterologist would advise you. If a patient is in remission, then no one needs to have visit every 2 months, but has to be established the requirement for a follow-up, because these days we don't follow up only to see how it goes in general, but we want to make sure, and we have tests, simple tests, to tell us more rapidly than symptoms that something may go wrong, and then be proactive and very likely to avoid bad outcomes or bad flares. So make good food choices. Good health means good nutrition. Managing your stress, easy to say for every one of us tonight. What I mean there is that, in fact, you should not be shy or feel feeble to look for help in terms of stress management. Disease itself may cause stress, but if anyone has a stressful life, even for a period of time, or is more prone to stress, any chronic diseases is affected by stress. So it is very, very important that these issues can be under control as much as possible, and that will improve capabilities of patient to be compliant and to have a better outcome. So track your digestive health history. That might be of benefit to many of you to monitor correctly and then put on papers a symptom that worries you to properly discuss with your physician at the next visit. So, living in a positive way with IBD, with proper treatment, indeed your life expectancy is similar to that of general population. It's 20, 30 years ago, maybe 30 years ago, we could not say that, but now there are many, many studies in populations that shows that, a patient being under control, even if a patient may face surgery or some impact on quality of life in period of times, the long-term outcome on life expectancy is quite similar to the general population. Obviously, there is always the odd cases that might be unusual, but for majority of patients, one should be reassured that being compliant with treatment, with physician visit, understanding the disease as much as possible, general, the life expectancy will be similar to general population. I think we're to the point of question and answers.
Okay, that's great. Thank you so much, Dr. Paré, for all that great information. We've got about 10 minutes left, and we've got lots of questions to go through. So I'm just going to read them off, and Dr. Paré will answer each one of them. I just wanted to say that I thought it was a really great way of saying how to best manage your disease is that the best way to ignore it is to actually keep it under control. I think that's great advice, and I hope that people keep that in mind when they're thinking that no treatment is really not an option. So the first question that we have here is, are there any new medications on the horizon that I should be aware of?
Well, there are new medications, obviously, that are tested in clinical trials, but the most recent medication are the biologics that we spoke about. But it's probably, I will tell you, that's more that within the next couple of years we will learn how to use them more effectively. More effectively meaning that it's likely that some patient may need a higher dosage of the drug than some others. So we're going to use more and more in the near future, and some centers do use it regularly more now, blood levels of the drug, and these will help to better manage the patient. There are also other drugs like what one drug is called budesonide, which is Entocor. Entocor is a drug used in Crohn's disease because it is effective for the disease of the small bowel. But there is a new formulation being tested now that will be the drug delivering into the colon instead of to the small bowel. So that might be a drug more effective in terms of side effect also than the regular steroids, because it is a steroid. It is not cortisone, but it is locally active instead of going into the full body.
Okay, great. So the next question is, are there alternative therapies to taking prescription medication? And if I consider doing that, what do I need to know?
Well, alternative therapy, we know, is a consideration for many, many patients having a chronic disease. Unfortunately, we don't have, good information or proper studies to assess alternative therapy. The most commonly mentioned alternative therapy that we hear about, are probiotics, but all the natural foods or natural medicine that we don't know exactly what they do can be also taken by a patient. So I will say that, I always tell my patient, and laughing, that if you're sick, it's probably better to take the prescription medication proven to be effective for your disease. And alternative therapies, if you're not sick, maybe you can take it as an adjunct therapy to maintain health. But to control the disease, as far as we don't have information or proof of efficacy for anything, I think it's probably not wise, at least, to start with alternative therapy.
Okay, great. And Lillian would like to know if there are any reasons that can help explain why the incidence of children under the age of 10 developing IBD has risen significantly.
Cannot tell you that somebody is telling that, but I'm not sure that I may not know the data itself that under 12. I think probably in children it's more easily recognized these days than 15 years ago. First of all, there are pediatric gastroenterologists in Canada, which it's most of the centers now, big cities, they are pediatric gastroenterologists. They use testing, some appropriate tests that we use in adults more commonly than they used before. So it's probably more recognized. Is it more common than before? I'm probably not sure. It's probably more common in Canada that we know than 15 years ago. It's Canada is one of the highest incidence country for IBD. It's unfortunate, but it's very, very common. So I'm not sure it's more common under 10, but it's more easily recognized, probably because physicians are well trained to recognize these. Yeah. Okay,
great. And Victoria is asking, what are the current recommendations for colonoscopy in IBD patients?
The recommendation to do colonoscopy?
I would imagine that's what she's asking, yes.
Yeah, okay. Well, colonoscopy, it's a wonderful test. Not fun for the patient. So I always say that when you have an IBD or Crohn's or ulcerative colitis, you have to deserve it to have it. Otherwise, you may have that so many times. Okay. So first of all, for diagnosis of the disease, this is needed. There is no other best test than colonoscopy. Okay. And yes.
And
for follow-up, it's needed too. Yeah.
Okay. And is there, a maximum or a minimum number of colonoscopies you can have in a year or over a lifetime?
Well, there is no cumulative risk of doing colonoscopy. It's just a unpleasant tests. And I think one I will say is that one will need to understand properly why a colonoscopy is done to himself or herself, to see what's the objective of the physician. Obviously, for controlling the disease, we like to know at some point in time beyond symptoms, but not necessarily in all patients, necessarily often, to make sure that it is under control. And then when a disease is long-standing, then we need to offer patient surveillance colonoscopy for the small risk of cancer.
Okay, great. And there's another question here asking if environmental causes are being considered as being the reasons for people developing IBD.
Yeah, well, I think there are studies. One of the good studies came from Alberta, from Calgary, where air pollution, and something into the air, I think related to sulfur, might be related to higher incidence of IBD in these regions. So it's only speculative research. I think it's interesting also, but obviously all IBD are intestinal disease, so there is much more direction at this point in time to the bacterial flora of the gut, or any antigen from the food that might trigger the disease. Although the disease is not caused by that, there need to be a genetic predisposition to have an IBD. But obviously, they are triggered. Perhaps pollution is a factor. Probably not the single most important factor, but perhaps contributing in some areas.
Okay. We have a question here that says, if I am steroid resistant, what are the treatment options for flare-ups?
Well, if you're steroid resistant, I think the main thing, well, assuming that a patient was not treated at this point in time with immunosuppressive drug, that will be the first consideration. But if being totally resistant, probably will be that there are remaining or still very active symptoms under steroids, and the best treatment will be biologics as a second step treatment.
Okay. And I know this isn't one of the questions that's been submitted, but it's one of the ones that we hear quite often at the foundation, and that's about people who have been prescribed steroids and then they need to wean them off. We hear quite often the physicians recommending that people never take themselves off, like that they decrease the dose on their own. Can you talk about that a little bit, the importance of making sure the physician is monitoring you as you decrease the dose of steroid?
Yeah. Yes. Well, first of all, for ulcerative colitis, we know that there is a type of threshold of dosage that one need to have to initiate a remission. And early studies, which are still the gold standard studies, show that it has to be 40 milligrams of prednisone per day initially. And then the speed of going down is really not determined by clinical trials showing that this is one best way to the other one. But we know that a flare is not there for 2 weeks. A flare is usually an acute inflammatory process that usually will stay there for several weeks, perhaps a couple of months. So that's why we want to start at one dosage, like 40, perhaps higher in some individual with higher body weight, and then decrease slowly every week or every 2 weeks. at a regular pace, and then the patient and the physician may monitor how the patient goes and modify the pace at which it is decreased to make sure that the patient remains under control. And it's better to do it under good advice of the of the physician. Yeah.
Okay, so we'll just do the last two questions here, and the second last one is: if I haven't had a flare for more than 2 years, can I stop taking the medication, or can I change the medication that I'm on?
Yeah. Well, it's obviously if it's to be honest, one of the main factors is to predict the long-term outcome is how long a patient was in remission. So the longer in remission, the more likelihood that the patient will stay in remission. That we know. But is it the natural history of the disease? Then no drug will be necessary, or is it because of the treatment and the patient is very sensitive, or the disease is very sensitive to the drug? I think there are risks of stopping the drug. If it is not a serious disease, if it was a mild disease or moderate disease, a patient may discuss with his physician to see and to observe the outcome. Obviously, there are risks and benefits. That obviously a flare will come one day. Obviously, that's for sure. But let's say that a flare comes with no treatment, about 50% of the patient a year, that a flare will come back at one day. And if treatment usually at this point in time is, I will say, not difficult to take, and if it is part of the life and making sure that this is the way to be like with no disease because it is quiet, it's probably safer to stay on the drug.
Okay. And the final question is, what long-term effects should I be aware of, particularly when taking a biologic? Are there signs that I should be looking for?
Well, I think the more we go, the more we know that they are very, 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 very safe drug. Okay, the main risk, which is increased more than on patient with no biologic, is serious infection. But serious infection, it's more more seen in patients who have Crohn's disease, because Crohn's disease patient may have abscesses around the anus, and when we call a serious infection, that may be it. Rare infection caused by a fungi or of that sort, about which normally an individual does not get infected to, may occur, but they will occur more commonly if a patient takes immunosuppressive at the same time. So it's more about infection than anything else. Lymphoma, very, 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 per se, it's very rare. The risk is very low.
Okay, that's great. And just before we sign off, I just wanted to make sure that we make everybody aware of some of the tools and additional information that we have available on CDHF.ca. So we have a smartphone app that works on Android and iPhone that can actually help you keep track of your medications and the bowel habits that are happening, your exercise, your weight, and you can share that information with your physician. And that's what Dr. Paré was talking about, that it's important to be able to communicate and have a good relationship with your gastroenterologist. Obviously, we've got information in the form of a fact sheet. And for Lillian, who was asking about the incidence of children who have IBD, wanted to let you know that we actually have now an interactive game for children who are undergoing colonoscopy. So it's a cute little interactive session that lets them know what they can expect to happen from the first visit that they have at the hospital to actually meeting the anesthetist and the nurse and the gastroenterologist and going into the operating room and waking up after the session. It was done with a university student from the University of Toronto, and it's just a wonderful tool. And then coming out in the next few days, we actually have a new resource called Guiding Your Gut, which is a resource guide for families who are living primarily with children who have Crohn's disease, but much of the information is appropriate for someone who is living with ulcerative colitis as well. And always, if you need any help navigating the site or if you have additional questions, you can always email us at director@cdhf.ca, and we're happy to help you. So that pretty much finishes up our session for this evening. On behalf of the Canadian Digestive Health Foundation, I'd like to thank Dr. Paré for sharing his insights and expertise. We'd like also to thank Shire Canada for partnering with us, and obviously to extend our very special thanks to you, our audience, for joining us. We hope the session has provided you with a better understanding of the therapy options that are available for you to help you manage your life with ulcerative colitis, and so that you can live positively with this inflammatory bowel disease. Again, please remember to visit CDHF.ca under our resources sections in the near future to review this web seminar and to take a look at the other resources that we have for you. Thank you again. Have a wonderful evening.